Welcome to the first Vivax Working Group Tech Talk webinar. My name is Dr. Kamala Trima. I'm a researcher at the Menzies School of Health Research, and I'm involved in the coordination of the Vivax Working Group. Thanks so much for joining us. People from all across the region have joined, and we're really excited to host this first webinar. Can I have the next slide, please? We have a great lineup of speakers and panel members, and I'd really like to welcome them all. Together with my colleague, Dr. Carolyn Lynch, I will guide you through today's program. Carolyn is MMV's regional advisor for the Mekong region and is working closely with countries to support them in improving current tools for Vivax radical cure and introducing new tools and approaches to radical cure. Before Carolyn is going to introduce the first speaker, I'd just like to remind you of a few of the mechanics of this webinar. Can I have the next slide, please? The audio and video of the attendees will be disabled, but we encourage you to post your comments in the chat box, and the intention really is particular in the later part of the webinar to be as interactive as possible. We will start with three 10-minute presentations. And again, then for the panel discussion, please make sure that you type in your questions in the Q&A box. Name the speaker if you have a particular question that is addressed to one person. Otherwise, if it's a general question, just type your question in the Q&A box. The other participants can then upvote questions by clicking the thumbs up to the questions. When you open the Q&A box, you'll see them. And we will prioritize those questions that seem to have most thumbs up and will therefore be relevant to the majority of the participants. At the end of the webinar, we'll have two polls, and we'd really encourage you to answer those. They will, as far as I understand, pop up on your screens. And just a reminder that this webinar will be recorded. Next slide, please. And I hand over to Caroline.
Good morning. So we're going to start with the presentation as Kamala has outlined, and I'm just going to introduce someone, I guess, who doesn't really need much introducing, Rick Price. Rick is a professor of global health at Menzies School of Health Research in Darwin, Australia, and also professor of tropical medicine from Oxford. And he's the co-chair of the APMEN Vivax Working Group. So I'm going to hand over to Rick to start his presentation.
Rick, can you unmute yourself, please?
I can, sorry. Good morning, everyone. Good afternoon or good night, wherever you are. It's great that we can all join together at this time of lockdown. And many of you will have been to our Vivax working group meetings where we meet face to face, but this is the first time we're kind of trying to meet virtually. So next slide. I'm going to give a brief overview on Vivax in the region and then look at some of the opportunities and challenges of radical cure, which is so vital for elimination, before handing over to Carmini Mendes. So in our region, there are 22 malaria endemic countries and about 3.9 billion population, obviously heavily dominated by India, Pakistan, China and Indonesia. But that puts 1.9 billion people at risk of malaria. And the latest estimates from the Malaria Atlas project published last year show about 9.6 million cases of falciparum per year and about 12.2 million cases of Vivax. Now that global cost is currently being put together by Angela Devine, and an estimated cost to healthcare providers and individuals of about $500 million a year. So a phenomenal burden in our region. We have made progress, and that slide down the bottom left shows you declining malaria in most places in the region, but clearly major challenges, notably drug-resistant falciparum in the Mekong, but also some unique challenges to Vivax. Next slide, please. So the Asia Pacific Malaria Elimination Network was formed in 2010 from 11 countries originally, and now has expanded up to 21 countries. So all malaria endemic countries in the region, except for actually Timor-Leste. And the target in this region is to reach elimination, or 90% reduction globally, 35 countries eliminated, and Asia Pacific region free from malaria by 2030. Now that is a huge challenge to achieve in the next decade. And so APMEN was formed by these 21 countries and partner institutes to come together and work to generate and share knowledge and best practices across the region. Next slide. And what we've seen, as I showed you in the slide previously, is that there has been a decline in malaria, very gratifying across many of the countries, but there's been a consistent rise in the proportion of malaria due to Vivax. And we noticed that nearly everywhere. On the top left is in Thailand, but also in South America, and more recently studies in Papua showing that nearly 50 to 80% of malaria in that region is now due to Vivax. Next slide. When we look at the 49 Vivax endemic, co-endemic countries around the world, you can see that that dotted line represents 50%, so the proportion of malaria due to Vivax. And in many places in South America, Sierra and Wipro, Vivax is now the dominant species causing infection. Next slide. So the reason that it's such a challenge is that we have the hypnozoite stages in that blue circle on the right in the life cycle, and they're formed in the liver, and they reactivate weeks to months later. So you don't just need schizontocidal treatment to clear the parasite, the blood stage parasites. You also need hypnozontocidal treatment. So the blood stage is what we use for all species of malaria to clear the symptoms and the fever, and that is chloroquine for Vivax, but also ACTs such as DHA piperacin and artemethyl lumefantrine. Whereas for if you want to get the liver stages, you've got to give a 8-aminoquinolone, and those are only 2 drugs that we have currently widely licensed for hypnozontocidal activity, and that's Primaquine and more recently tefenaquine. Next slide. So there are a variety of Primaquine regimens recommended, and these are just a few of the options. The most common regimen is the low-dose Primaquine regimen over 14 days, and that is in most countries. So that is a total dose of 3.5 milligrams per kilogram. Now the total efficacy of Primaquine against the liver stages is related to the total dose administered. So you can give a lower dose, a total dose of 3.5, and you can spread it out over 14 days, and that's 15 milligrams per day in an adult. In China and Brazil and a few other Central American countries, they actually stack it in a bit tighter, the same total dose, but they give 30 milligrams over 7 days. And then in areas of high relapse periodicity, such as the Chesson strain in Papua and Papua New Guinea, a higher dose might be recommended, 14 days, but this time giving 30 milligrams and extending from 7 to 14 days. And in those people who are G6PD deficient, the current recommendations are that you extend that over 8 weeks. So 45 milligrams in an adult given once a week for 8 weeks. Now the WHO guidelines in 2015 recommend that, of course, because of G6PD deficiency, you should be doing G6PD testing prior to giving Primaquine. But there's also going to be some challenges in areas where G6PD status isn't known or G6PD testing is unavailable. And that's a very hot, contentious topic. And we must strive to give G6PD testing where we can, but the risks and benefits need to be taken into account. Next slide. So G6PD deficiency is an inherited enzymopathy. It's an X-linked disorder. It has, males can either be hemizygous deficient or they can be normal. The females can be heterozygous, so they have an X and a Y chromosome, and so they can be intermediate deficient. And on the left-hand side, you can see a nice heat map which shows the G6PD prevalence around the world. And you can see it's highly variable. It's quite common in malaria endemic countries, probably because it protects you to a degree against severe malaria. and the deficiency distribution or prevalence ranges from about 1 to 25%. The schematic diagram on the right-hand side is only a schematic diagram, and it tells you that as your enzyme activity falls, there is an increasing rise in hemolytic risk. Now, most of the G6PD testing are done at the 30% using an RDT or a FST, a fluorescent spot test, and you can diagnose with a qualitative test at 30%. But that won't capture the heterozygous females who are intermediate between 30 and 70%. And to get to that higher level of diagnosis, we have to use a quantitative test such as a spectrophotometry or a biosensor. Next slide, please. So there are huge challenges in delivering radical cure, and I think it's worthwhile remembering that the greatest burden of Vivax is actually in children and in remote rural areas, and this is where the health systems are weakest, and it becomes most challenging to actually provide a drug which has to be treated, continued for 14 days, and where you need to do G6PD testing. So those blue bars show you the proportion of Vivax in rural areas, and you can see, especially in Afro and Wipro, more than 60–70% are in the remote rural areas. And the yellow bars down the right there show the proportion in children. So nearly 50–60% in some places are due to children. So we've really got to make sure that we're hitting all people who need to have radical cure. So remote access and delivery is a problem. There's also a variable risk of relapse. So in areas such as Papua and PNG in Brazil, you may get 80% of people will have relapses, whereas actually that might be far less in parts of India and Korea, where maybe just 10 to 20%. So a very variable risk. And then if you're giving a 14-day regimen, there are issues over poor adherence and effectiveness. There's also, as I described, variable G6PD deficiency. And then there's the feasibility and cost of G6PD testing. As we'll hear, many countries do not routinely use G6PD testing, partly because of the cost and the feasibility and the supply chain. And then to put all of that into the mix, you also need sustained funding and many other challenges that I think we'll discuss in the panel discussion. So heterogeneity is the buzzword here, between different countries having different challenges in terms of delivering radical cure. Next slide. So the APMEN working group, a Vivax working group, was established in 2010, and this brings together those 21 national malaria control programs at the center of what we're doing, but also bringing in partners from research and academia, from the World Health Organization, networks, funders, industry, and public-private partnerships, so that we can work together, identifying the knowledge gaps and trying to build the evidence around this, particularly around diagnosis, case management, and surveillance. Next slide. So here's the challenge. This is the long and the short of it. We need to give enough Primaquine or Tefenoquine to make sure that we get a cure, but the more drug we give, the more likely there is to be a hemolytic risk. And so we spread out the dose, and most often we spread that daily dose out to 14 days. And there's the low dose, 15 milligrams over 14 days, which is probably the most commonly used policy. But then you have issues with adherence. And if you increase that in G6PD deficiency to 8 weekly, it can be even more of a challenge in terms of getting that adherence. So there are ways in which you can do that, but you can't just give people tablets and expect them to take a 14-day regimen. Or you can pack in your treatment course shorter courses, and you can give a high dose, maybe 60 milligrams over 7 days in some places, or even a single dose of Primaquine. But the shorter you give, the higher the daily dose, or the sustained long half-life of Tefenoquine, makes it absolutely vital that you're giving G6PD testing. Now, some people would say you've got to give G6PD testing for everybody, but you really have to focus also on those people given the higher dose at the left-hand side. So there's our challenge, adherence versus a G6PD testing. Next slide. So we do have some great new tools that have come online in the last few years. We have better parasite diagnostics, and so new better diagnostics, RDTs for Vivax are coming along. We have some ultrasensitive diagnostics, and we also have potentially things in the pipeline that may test for hypnozoites in the liver. In the last few years, we've also had a whole host of different G6PD diagnostics, qualitative RDT tests from CareStart, and more recently, a very exciting development with the biosensor from SD Biosensor, which is a quantitative assay, a handheld device there, and you can see it down there. Some great collaborative work there done by PATH in terms of developing these tools and seeing how they're working in the field. And we'll hear a bit more about that later. And then we have different treatment regimens. So notably Tefenoquine, which is a single dose radical cure, which is now licensed in the UK, in America and Australia, but also increasingly in some of the countries. And then we also have other regimens such as a shorter course high dose Primaquine. But both of these are going to have to come with G6PD testing. So that is going to be the challenge. So next slide. So that's all I'm really going to say, is that we can eliminate Vivax, and we have eliminated from many countries using the tools that we have to hand. But I think we have to realize that if we're going to meet the 2030 ambitious target of elimination, we're going to need new tools and new strategies to make sure that we can give Primaquine safely and effectively to as many people as we possibly can. I think it's also worth noting that there's no simple universal solution that's going to come which is going to fit everybody for safe and effective radical cure, because the challenges are so great within each of those countries and endemic environments. And that marked heterogeneity of risks and benefits means that we've got to have an integrated package of interventions tailored to the local context and also the socio-political environment. So that's the theory. I'm going to hand over to my friend Carmini Mendes, who has got huge experience in Vivax and was part of the team who eliminated malaria from Sri Lanka. And she's going to tell you about the reality of how this works in the field. Carmini.
Hello, good day to all of you, and thank you, Rick. So after that excellent overview of radical cure by Professor Price, let me in the next 10 minutes talk you through some practical aspects of implementing radical cure with the tools that we have today. Could I have the next? Yeah, that's fine. We all know the problems presented by radical cure options that are most commonly used and available to us today, which is the standard regimen of 14 days of Primaquine. And the difficulty is to ensure safety by excluding G6PD deficiency, as Rick mentioned, and achieve adherence in a 14-day regimen. Both these are difficult, and so we can wring our hands in despair and say we can't do this. But in fact, several countries with highly endemic Vivax malaria have successfully implemented radical cure in the recent past, and they have even eliminated malaria. There are so many countries that are also unfortunately not implementing radical cure to any significant extent because they are unable to overcome these challenges of safety and adherence. So let us examine this issue in a bit more detail. The next slide. Let me first deal with the issue of adherence, which probably is the easier one. There is plenty of good published evidence for, instead of just slapping the medicines into the palm of the patient and saying, take it for 14 days, that if care is taken to counsel the patient, explaining the importance of taking it, that adherence is as good as if treatment was supervised. So there is a way out of this problem. There are other options as well. Caregivers who very often accompany the patient to the clinic can be asked to supervise the treatment. And I know that in some countries, especially those who are close to elimination, where the burden of Vivax is quite low at that point in time, health workers visit the homes of the patient every third or fourth day, and they inspect the empty packaging or remaining medicines as a means of checking how much has been taken, which has also worked very well. And finally, there is, of course, the option of directly observed treatment, which isn't easy for the health system to do, but there are special situations in which this has also been done, and I will refer to this a little bit later. Could I have the next slide? Now, to the more difficult problem of excluding G6PD deficiency before prescribing Primaquine in a clinical setting that malaria is being treated at. So how can this be done? There are quite a few brands of commercially available rapid diagnostic tests for G6PD testing. None of these are pre-qualified by WHO. And this means, of course, that their performance is very variable, and countries have found them not to be very reliable, meaning they have found discrepant results between two testings of the same test, and differences between the outcomes of these and qualitative laboratory methods. The cost of these tests, RDTs, is not a major consideration. They are affordable largely. But also sometimes their deployment, particularly the interpretation of results, could be problematic, such as in the hands of community health workers. So given all these limitations, the question is, how can we and how have some countries managed to overcome these? The question, I suppose, is G6PD testing mandatory for prescribing 14 days of Primaquine treatment? The answer is yes, it is, according to WHO. But here is the clause in WHO's own recommendations, which says that when a patient's G6PD status is unknown, and when G6PD testing is not available, a decision to prescribe Primaquine must be based on an assessment of the risks and benefits of adding Primaquine. So it's a risk-benefit assessment that we have been asked to do. The benefit is obvious. I don't think you can eliminate Vivax malaria without preventing relapses. So assessing the risk and the benefit is exactly what countries that have successfully eliminated Vivax malaria have done, which is the following. The next slide, please. First of all, in most or all countries, there are published records from studies that have looked at the prevalence of G6PD deficiency. And they give a general idea of the degree of the problem, and that helps. You know, what are the variants that are prevalent, and what is the extent of the prevalence. That could be the first step. So you have a general idea of the G6PD status in the country, and then they've tried to minimize the individual risk to the patient. For example, ask for a past or family history of hemolysis after any medication. And if there is absence, you don't get a past history or a family history of such evidence, then prior to prescribing Primaquine, they counsel the patient, explaining the risk of hemolysis, how to recognize the earliest signs of hemolysis, and asking them to stop the medication and seek medical help at the first signs of hemolysis. This way, in most cases, the dangerous levels of hemolysis can be avoided. Now, if in a country or an individual, the risk is either high or unknown, then there is the final recourse to another strategy, and that is to use a weekly and not a daily dose of Primaquine for 8 weeks, which some countries are in fact using. I'll come to that a little later. So there are ways of getting around the problem and using Primaquine for radical cure. But you might say this is all theory. So now let me talk about a few examples from countries which I hope will be inspiring for all of us to scale up radical cure with Primaquine, which is the solution we have right now today. The next slide. Can I have the next slide? Okay. So the first example of experiences is from Sri Lanka. Just 3 years before Sri Lanka eliminated malaria, on this top left slide, there was an outbreak of Plasmodium vivax malaria, which occurred in a series of army camps, which were located on the edge of a major river within a national park in the deep south of the country. Now, the location of this outbreak is shown in the map of Sri Lanka, colored in pink. And you can see the river, if you can see this in the photograph, the banks of the river, where there's a whole lot of army soldiers lined up who are being given a lecture on what is going on. This outbreak of Vivax was squashed by some intense activities of vector control and treatment. And so I've shown the epidemic figures, the incidence in the graph on the left lower picture here. And there are a lot of interventions that have sort of indicated here, but I'm not sure you can read it all. Could I have the next slide, please? So in addition to all those interventions, this, of course, was a Plasmodium vivax outbreak. So they diligently deployed 14 days of Primaquine treatment, which was the national treatment policy, of course, in all the patients quite early in the epidemic, as I've shown here. At this point. Now, without testing for, this was done without testing for G6PD, because this was in 2009, then before WHO made G6PD testing mandatory in their Vivax guidelines. But then and of course, rather than test for G6PD, what they did was they took all the precautions that I discussed a few minutes ago. But the epidemic went on, the outbreak went on, and they soon realized that just prescribing Primaquine will not do. And somewhat late in the outbreak, they made Primaquine administration as into DOTS, directly observed treatment. Now, remember, nearly all these patients, Vivax patients, were soldiers in the army. And what they did was, instead of sending them home after curing the illness, which was the usual practice, they kept the soldiers in the barracks for 14 days after cure, and they administered Primaquine as DOTS during the 14 days, and only thereafter were they given leave to go home after the illness. So this worked, and of course, this is not the only reason why the outbreak was controlled, but it was, I think, one of the very important reasons. The next slide, please. Another country that has successfully eliminated malaria, including Vivax, of course, is Timor-Leste. Only a decade ago, they had a very high burden of malaria, including Vivax, and now they've eliminated the disease. The last case of malaria was in 2017, and they used a lot of interventions, including, of course, 14 days of Primaquine for radical cure. Now, at the beginning, they did start using the RDTs for G6PD testing, but they soon realized that the results were very inconsistent between tests and so on. So very soon they gave up on the testing on a large scale, and then they resorted to taking all the other possible precautionary measures before giving Primaquine. Now, the next slide. I'd like to remind you that in most situations, it's possible to eliminate Vivax malaria with the current tools we have today. And this is the proof. All the three countries that I've shown here, Sri Lanka, Timor-Leste, and Bhutan, have had high burdens of Vivax malaria. And they deployed Primaquine for 14 days as radical cure, with or without testing, using the safety precautions that I described before. Now, they didn't actually defy WHO recommendations. Some of them were well before WHO came and said, look, the risk is too high. In every patient, you've got to test for G6PD before giving Primaquine. And some of them were after, but they used the RDTs, but they didn't rely entirely on the results of the RDTs. They took all the other precautions that we discussed before. Now, we often say that Vivax is difficult to eliminate, and this is a fact. And that therefore, Vivax elimination is usually achieved several years after the elimination of falciparum. We say this. But here you see that all three of these countries, Vivax and falciparum, were eliminated together in the same year. The next slide, the red lines, by the way, sorry, can I go to, yeah, the red lines show Vivax and the blue ones show falciparum, and you see that the high burdens of both were brought down effectively almost at the same time. The next slide. I must emphasize that Vivax, okay, so this, I think I'm going to, this is about the prevention of reintroduction phase of malaria in countries, which I'm not going to talk about. The slide is there, it can be referred to later. Could I have the next slide, please? I must emphasize that Vivax elimination and even control greatly depends on radical cure, but it's not the only thing that it depends on. Early and effective treatment of cases, which is anticidal treatment, and evidence-based vector control are extremely important for Vivax elimination. And all of these countries deployed not one, but all of these strategies. Now, to conclude, let me say that there have been no recent reports of life-threatening hemolytic events following Primaquine in countries using this approach, and that they have recently eliminated malaria, which have recently eliminated malaria or are in the prevention of reintroduction phase. However, the risk of life-threatening hemolysis with Primaquine in a G6PD deficient individual is real. Every safeguard, therefore, must be taken to prevent this. And it is important to assess and mitigate this risk if we are to eliminate Vivax malaria. So I think that's the last of my slides. I'm going to hand over now to Kamala Treimer and Caroline Lynch for the next part of the Tech Talk. Thank you.
Thank you very much, Kamini. Very impressive, the efforts made in Sri Lanka with all the tools that we have available for since a long time. I'm going to move a little bit towards the new tools that we are having and give some background on the last Vivax working group APMEN meeting in October last year. So as Rick already highlighted in his talk, the Vivax working group, can you go back to the first slide still, please? The Vivax working group has held annual meetings since its start, really. And those meetings bring together a range of very different people from researchers and country partners in the middle, really. And the aim is to initiate this dialogue, as Rick highlighted. And the National Malaria Control Program is in the center of this activity. So the last year's meeting was held in Nepal and brought together more than 100 participants across the region. And very similar to this webinar, the overarching theme of the meeting was to explore how those new tools that we finally have can be potentially introduced into policy and practice. The main meeting was then followed by a workshop specifically for country partners to dig a little bit deeper in those issues. Next slide, please. I'll try and provide a summary of those discussions and what has happened since then. There were three main questions that we tried to address. The first one, what are the remaining evidence gaps that are important to address when it comes to the introduction of new tools? And when I say new tools, I mean short course Primaquine, Tafenoquine, and the respective diagnostic tools, particularly for G6PD deficiency. Most countries will rely on WHO recommendation before changing their own policies, but those recommendations are most likely to be very broad and not very specific. And so the discussion around this question really was trying to think what are the additional questions that country partners feel need addressing before they can move towards policy change, and addressing those questions that are relevant for their country context. The second question that is already up there was around the policy pathways and how those might be different for different new tools and in different countries. So changing a dosing regimen for Primaquine obviously has a very different pathway to introducing a new drug, and similarly this would be the case for new diagnostic devices. And having a clearer understanding of those pathways hopefully helps to accelerate change. Next. The last thing we looked at were what we call roadmaps for the introduction of those novel tools in the context of the elimination goals. So starting at the elimination deadline and then kind of moving backwards to the current status. In today's talk, next, I'll focus on the first two questions. Next. And I'm sure some of the aspects of the third one will be highlighted during the panel discussion later. Next slide, please. I'll start with the next slide. No, yeah, perfect. I'll start with the first question, the gaps. Next slide, apologies. So during the main meeting in October, we had roundtable discussions to explore this question around evidence gaps. And country partners and research partners were seated on different tables to discuss this independently. Each table had a facilitator to help with the discussion and note takers today to take detailed records of the points raised. The tables then presented back to the overall group their highlights from those discussions. And a total of 9 topics were then distilled from those discussions. And those were topics that were frequently mentioned across all the different tables and were highlighted as important. Next slide, please. So those are the 9 topics in no specific order, just put on this slide. And as you can see, this included questions around the robustness of G6PD tests, the effectiveness of current practice, questions around the effectiveness of new treatments, safety, cost issues or cost effectiveness questions, and feasibility. So during the workshop, where only the country partners were in attendance, we then asked each of the country representatives to rank those questions by importance for their own setting. Next. So with 1 being the highest priority for their specific country, and then 5 or 6 lowest priorities. And you can see here on that slide an example of this exercise in the workshop. Next slide, please. And when we then averaged the ranking, you can see that the question around the comparative effectiveness of the different option was ranked highest. And I'd just like to emphasize here that effectiveness is very different from efficacy. So efficacy we usually measure in in randomized clinical trials that have very controlled settings, whereas effectiveness is really the question, how well does the drug work in a real world setting? And that's where all the issues around adherence really come into play. So this question was then followed in terms of the importance, and in the ranking followed with the issues around G6PD diagnostics. Questions perceived less important were effectiveness of current practice and the overall Vivax epidemiology. The findings from those ranking exercise were confirmed in individual interviews next. After the meeting with three selected countries, and they confirmed that their ranking is still valid even after the meeting, and after having some further discussions with their colleagues. Next slide. So this graph takes into account not only the ranking exercise that I just showed you, but also the other roundtable discussions from the entire meeting and the workshop. You can see on the left-hand side the different research topics or the different issues raised that needed addressing, and then on the x-axis the continuum of change from the current practice to clinical trials and to implementation and policy change. In dark blue we have the country partners, and in light blue the research partners, and the size of the bubbles present the frequency the topic was raised in those discussion rounds. And you can see here there is a particular focus for country partners on the topic of G6PD testing, but also on cost effectiveness and effectiveness of different options. Next slide, please. Moving on to the second question around the policy pathways. Next slide. This question was mainly addressed in the country partner workshop, so in the smaller part of the meeting, and is really an attempt to document some of those processes that are needed in the policy change process, and understand the differences between the countries and highlight the different pathways for the different options for new tools. There is obviously not enough time to really go into a lot of depth within the workshop, but we followed on from the workshop with additional interviews with partners who were at the meeting and additional stakeholders in some of the countries. And in total, we did this in 7 countries. You can see this on the map here. going from east to west, Papua New Guinea, Indonesia, Vietnam, Cambodia, Sri Lanka, Pakistan, and Ethiopia, even though Ethiopia obviously is not part of the Asia-Pacific region, but they have been invited to the most recent Vivax working group meetings over the last two or 3 years, and they're almost an honorary member now. Next slide, please. So this work is still ongoing, and I don't want to go into too much detail, but I'd just like to highlight the incredible heterogeneity in terms of the complexity of the processes that are in place in different countries. On the top, you have an example from Cambodia, and thanks for Dr. Solly, who will be on the panel later, to helping us put this together. Again, this is very preliminary and still needs to be verified to some extent, but it really highlights just want to highlight the different groups and committees that are involved in the policy making process, how things are going back and forward between those committees and those entities before a policy change can be approved. And compared to Pakistan, and thanks to Dr. Abdul, who's also going to be on the panel for providing a lot of this insight, where the process is much, much simpler within the National Malaria Control Program, and therefore seems to be much more streamlined. Next slide, please. So even though this, as I mentioned, is still ongoing, we can already see that there are quite large differences between countries. What is common for all of those countries that we looked in is that the National Malaria Control Program, of course, plays a critical role both in the initiation of the process as well as in influencing the process until the end. It's a fluid process. There is not a lot of documentation in terms of the terms of reference for those committees are only available for very few countries. Again, broad across those countries, seems that there is very little consultation with the Ministry of Finance. And what I found really interesting as well is that there seems to be the process seems to be specific for the malaria program, and there's very little awareness of how this might be different for different other diseases. Next, as indicated, this is still ongoing work, and we'd be more than happy to increase that and get more insights in this and expand to more countries. So if this is something you're interested in and are from one of those countries that we haven't covered, we would love if you get in touch with us. Next slide, please. So the last question, as I mentioned before, was around the detailed planning in the context of the elimination timeline. Next, you can see a picture here that just gives you a bit of an idea kind of how we try to do this during the workshop. Starting at the elimination deadline and then trying to work backwards. I'm not going to go into the details as I think we'll hear much more in the panel discussion. Next slide, please. Before we move on to the discussion, I'd just like to acknowledge our host for the meeting in October in Nepal and thank them for their incredible hospitality. It's been an amazing couple of days there. Also like to thank the facilitator, moderators, and note takers during the meeting. They've done a fantastic job. Thanks to Veronica and Joss, who've done those additional interviews and pulled together those data together with Caroline and myself. And then obviously all the participants of the meeting and the workshop and those who participated in the additional interviews. Next slide. With this, I'll hand over to my co-moderator.
Hi, fantastic. Thank you so much to the presenters. It's covering quite a lot in such a short space of time. We're going to move on to the Q&A panel discussion now. So I'm going to present, just introduce the panelists. We're going to start with 3 questions from myself and Kamala's side. I noticed that there's a lot of questions coming up in the Q&A already, which is excellent. So can I please encourage you to upvote questions that are in there that you think are pertinent, or add on additional questions there, and then we'll get to those after the initial 3 questions. So just to start with the 3 panelists, who I'll ask to turn on their videos as I'm doing this. We've got Dr. Lek de Soleil, who's the Deputy Director for the National Centre for Parasitology and Entomology and Malaria Control in Cambodia. Dr. Abdul Majid, who's the Malaria Advisor for Policy and Strategy at the Directorate of Malaria Control at Pakistan, and Dr. Rose Nani Bintu Mudin, who's head of vector-borne disease sector for the Ministry of Health in Malaysia. So these three panelists obviously represent folks at the forefront of trying to control and eliminate Vivax radical cure from across the Asia-Pacific region. So I'm going to start with one question, and then I'll hand over to Kamala for the next question. What we'd like to understand from our panelists is what your current radical cure policy is, and maybe comment a bit on how you think you're doing in terms of achieving coverage. Within that question, what proportion of patients do you think who should be receiving Vivax radical cure are actually receiving it at this current time? Perhaps we'll start with Dr. Abdul. You're muted, sir.
Thank you. Good morning, good afternoon, and good evening. It's really a pleasure to be part of this panel discussion. As far as this policy is concerned, Pakistan is one of the highest Vivax burden sharing amongst highest Vivax burden sharing countries around the globe, and approximately we report more than 300,000 cases every year, confirmed cases. So with this, the current policy for the treatment of Vivax is to treat all the Vivax cases with chloroquine for 3 days, and anti-relapse therapy is given for 14 days at the rate of 2.5 milligram per kg body weight, and Primaquine is given. So with all the precautionary measures which are advised by the healthcare providers. So of course, the children less than 5 years and the pregnant women won't be advised all these treatments. As far as the coverage is concerned, I would say, in my opinion, it's very low. The WHO estimates for Pakistan total burden is approximately 1 million cases each year, and approximately 85% of 1 million are Vivax cases. So we are diagnosing and treating only more than 300,000 cases each year, which means we are missing a lot. So the coverage, I would say, it's not, it may be less than 50%, especially while we don't have the anti-relapse therapy available in the private market. It's only the government of Pakistan through WHO and Global Fund support which is providing Primaquine to the healthcare providers trained on. So the coverage is quite low, and we don't recommend any G6PD testing before. It's not mandatory to have G6PD testing done prior to the anti-relapse therapy. Yeah, so that's from my side.
Thank you so much. And Dr. Soleh, could you comment on the situation in Cambodia? Dr. Soleh, you're muted.
So thank you. So in Cambodia, I think we have now a burden on Vivax, so it's coverage almost 91%. But currently, our policy for PV radical cure, so it's only male patients so who will be eligible to be tested due to G6PD RDT quantitative status. And currently, only this G6PD RDT test is available in the country. But according to our treatment guideline, so for male patient over 20 kilogram with G6PD normal, so they will receive 3-day ACT and 14-day Primaquine with follow-up by phone call, by health center staff, so on day 3 or day 7 and day 14. So to check the drug adherence and if there is any side effect. So currently implementation, so as we received the progress of data. I think around 1,800 PV cases, have been detected in 4 provinces. So we have more than 800 detected by health center, and I think we have 100 person receive PV radical cure, and we have almost 70% that they have a test for GCPD. But from we learn experience from the implementation so far, so we all now want to move up to scale up throughout the country, and then we all now discuss about the GCPD quantitative test. So I understand that the tests are already approved by Global Fund, and hopefully it will be arrive in the country at the end of this year. And we are now also working with the partner to update some guidelines, and also discuss with WHO and some partners, so how to roll out the quantitative GCPD test in the future. But we have also planned to include the remaining health center for the PV, for the radical cure in the whole country, to implement it in end of this year. I think this is just the issue that we learned from the implementation so far in Cambodia. So I just have briefly here for your information. So thank you.
Fantastic. Thank you. And I'll move over to Dr. Rose now to share her thoughts.
Yeah, thank you, Caroline. Very good day to everybody. I think in Malaysia, before 2016, the treatment policy for Vivax in Malaysia was combinations of chloroquine and 14 days of Primaquine. However, in 2016, the treatment policy was reviewed following strong evidence Vivax chloroquine resistance in the country. And Malaysia uses the combination of artemether lumefantrine and 14 days of Primaquine as first-line treatment for Vivax malaria since 2016. And all patients diagnosed with malaria in Malaysia will be admitted to hospital for them to complete their treatment. And this is to overcome the compliance issues in the treatment. And we do follow up. So in the 14 days, they will be in the hospitals. After that, we will follow up them on the day 21 and on the day 28, and also monthly follow up for 1 year. And our coverage for this follow up is about 80%. And we have a standard regime. We have a standard guideline used nationwide. We have you can get that in our website. And this we do. I mean, for the radical treatment, it is implemented well in Malaysia.
Thank you very much, Dr. Rose. It's very interesting to see the differences between those 3 countries. So I guess the next question I would like all of you to comment is kind of looking forward. What are your considerations for the future? And I know Solly already alluded to some of those, but so what are you considering to introduce new tools? If you're considering the introduction of new tools, which ones are they? And what are your main considerations in making those decisions? Or do you think you're going to stay with what you're currently having? Perhaps we'll start the other way around. Dr. Rose, do you want to start this time?
Thank you, Kamala. For Malaysia, Malaysia is considering to make Primaquine available in Malaysia, and for radical cure for Vivax or malaria, and also for prophylaxis treatment. And subsequently, we will review our treatment policy for Vivax and ovale malaria, as well as to include Primaquine as a new option for prophylactic anti-malaria. And Malaysia will also study the need to make available the point of care quantitative G6PD testing. This will require local validations of WHO pre-qualified POC kits.
Thank you very much, Dr. Rose. Dr. Soleh, do you want to go next, please?
So yes, so as I just mentioned earlier, because when we understand about some challenge from the implementation in 4 provinces, so we are now planning to use quantitative G6PD, because we think that we still have not yet cover about the children and female, so that's why so our national program planned to speed up. So by end of this year, so hopefully we will use the new tool of diagnosis, but we reminding to use treatment as the same. So this is from Cambodia that we plan to do in the near future.
Great, thank you very much. Dr. Abdul, your perspective, please.
Yeah, so Pakistan, like, I mean, currently we are very sure that we have to give Primaquine as anti-relapse therapy even if G6PD testing is not available. However, I think, I mean, Pakistan is really under discussion to have more evidence generated as far as the various dynamics of Vivax are concerned, and also about the prevalence of G6PD amongst different ethnic groups in Pakistan. So I mean, with scarcity of the evidence available at the national level or at the local level, we simply follow whatever is recommended by the WHO for our region. However, I mean, it creates interest in our technical working group people, which is the highest forum where policy recommendations are made. That at least we should have some more information about the prevalence of G6PD, adherence issues, the relapse rates, things like that. So once we have this more information available, I think Pakistan would be moving, like Professor Rick Price has mentioned, that the issues with adherence are there with 14 days. So perhaps once we have WHO pre-qualified, at least quantitative testing is qualitative testing is available, WHO pre-qualified, then perhaps we can shift to 7 days high dose Primaquine. And afterwards, I mean, once the quantitative testing is also available, then, but it's very long way to move there. So perhaps the first step is to have the WHO pre-qualified qualitative testing available for G6PD, and the local well-established evidence regarding different dynamics of Vivax and G6PD prevalence. So we move towards 7 days high dose Primaquine.
Fantastic. Thank you very much for your answers. And this is the last question for myself and Kamala. And I encourage the audience, do please put your questions in the Q&A or vote up the questions that are in there. And we're going to move to those after this last question that we've got. And to our panelists, that question is, what are the main challenges? I mean, you've touched on some of those, but what are the main challenges for radical cure in your respective country? And how do you think you can address them? And within that, what are the contextual factors for you in determining either how to improve current tools or when thinking about new tools that are becoming available? So perhaps we'll start with Dr. Abdul this time.
Okay, so the challenge is, like I mentioned earlier, the biggest challenge for us in Pakistan is the coverage. Like I said earlier, perhaps we are diagnosing less than 50% of the malaria cases, which, I mean, and the national policy, national guideline says that Primaquine would be given only to the confirmed malaria cases. So there are more than 50% of the cases being diagnosed on clinical grounds. They would be given chloroquine, but Primaquine, as per national guideline, we don't recommend. So until and unless it is confirmed either parasitologically through microscopy or through RDT, I mean, yeah, we won't recommend to keep Primaquine anti-relapse therapy. So this is the biggest challenge we are missing. And I mean, in every peak transmission season, we get the new cases of Vivax. Perhaps these are the relapse cases in actual. So this is the one challenge, the coverage. And second one is the availability of the Primaquine. As I mentioned earlier, government of Pakistan is not procuring Primaquine. We get Primaquine from WHO and from the Global Fund. It is not available in the private market. The patient treated in the private through private GPs, private hospitals, they won't get anti-relapse therapy. And of course, the issues with the capacity of the healthcare provider in terms of explaining the precautionary measures, I mean, the correct dose of the Primaquine. These are some additional challenges. And so I think, I mean, adherence issues, of course, I mean, we, like Professor Mendes mentioned, we don't really know what are the, and we have never studied these issues of adherence. So we just prescribe 14 days anti-relapse therapy and the patient is out. So we don't really know whether, I mean, they are fully taking the complete dose of Primaquine. So these are the few challenges apart from many other.
Great, thank you so much. Dr. Soleil, would you like to respond to that question?
So I was currently challenged, so we understand that according to malaria information system from earlier this year, from January to May, so we understand that there's around 60% of PV cases are currently diagnosed at the VMW. But however, during our pilot implementation, we did not include VMW. It's not trend and about the PV radical cure. So we need to, when we scale up in the future, so we need VMW to refer the case, right? To ensure that PV radical cure will be tested with G6PD. So hopefully we will use VMW to refer PV case in the community. And then when we implement of quantitative G6PD RDT, we understand that there is some difficult in interpret of result because the RDT is just based on the chart color, and it's difficult for distinguish between G6PD normal and deficiency from the health center staff. And as practical, so most of health center staff also busy with other community, and it is difficult for us, to understand that the patient PV can treat all the time when they access to the health facility. And then I think there is some also challenge in side effect management. So as a real-time reporter, so we see that almost the reported from the health facility. So we need to do some investigate, to understand well. So whether the side effect is due to the drug. So that's why we need health center and hospital level and to report to the PhD or to CNM to understand this process. And since we use the health center to follow up with the patient, I think through the phone, I think the patient or have sometimes to reach, to the population without the good phone connection, and then we understand there is some PhD or OD to assess the health center staff really need to make a phone call or not. So this is some challenge during we implement the PV radical cure. Yeah. So so I have only some main challenge of this issue.
That's great, thank you. That's complex challenges that you're describing. I'll move to Dr. Rose to give us your thoughts on this question.
Yeah, in Malaysia, in the Ministry of Health Policy, all newborns in Malaysia will be tested for G6PD deficiency. So it's our policy. But there are, of course, there are challenges in managing malaria. Our main challenge is the registration of Primaquine, because the registration of Primaquine usually take a longer time. We estimated about 250 days of working days to register one drug. So and the registration of Primaquine in Malaysia is depend on internal policy of the producer. For example, for the company who produced the drugs. And Malaysia was informed that registrations of Primaquine can only be done after the drug was registered in India, where the origin country that produced the drugs. So this is the challenge that we face to register Primaquine in our country. The second challenge is to review the needs of point of care quantitative G6PD testing, because currently all our facilities will be able to diagnose G6PD, but it is done in the clinics or in the hospital. So we would like to have it at the point of care, for example, in the small clinic in the urban, in the rural area. So this will require a local validation of WHO pre-qualified point of care kits, which could take 6 or 12 months to have these qualifications. And Malaysia will need additional budget also to make this equipment available in the identified area that we wanted to use. So apart from that, we also need to review our treatment policy to add in Primaquine in the policy regimes of the malaria treatments. I think that is our main challenges in Malaysia.
Thank you very much. Thank you very much, Dr. Rose, and thanks to all the panelists. Can I ask Professor Kamini and Rick to switch on their cameras, and then we'll move over to the questions from the audience. And I'll go by, I'll start with the questions that received the highest upvoting. And this is a question to both Kamini and Rick. So given the current tools, given the current tools could work to eliminate Vivax malaria, why should we focus our energies in scarce finding and scarce money and funds and everything, finding new tools and have another cycle of finding optimal delivery strategies? So Kamini, do you want to perhaps start, and then Rick, if you want to chip in later?
All right. Can I be heard? Am I being heard? Yes. Okay.
Yes.
So yes. So what basically I described as being possible, and I've showed examples of countries that have done it and eliminated malaria using the current tool. It's a lot of effort. It's, as Rick said in his presentation, there's a lot of heterogeneity in in the countries, in the situations, in the G6PD status, in the burden of Vivax malaria, in the strength of the health system. They're very variable. And depending on what combination you have, you've got to put in an effort. Sometimes it's a major effort. And in those situations, we could do with much better tools. We could do with a quantitative point of care, reliable point of care tests. I mean, you've seen when I described the precautions that the countries have taken so far, they're time consuming. They require an effort, and these countries have put that effort. But it depends. I mean, if the burden of Vivax malaria is huge just now to begin with, then you can do with some more help, better tests, to estimate G6PD status, medicine maybe that can be given, a single dose one day would really help in those situations. So that's the reason. I'm not saying you can't. I mean, you can. It's been proven. Some countries have even eliminated Vivax, starting with a huge burden of malaria. But then they've had very good health services, very committed malaria programs, and they were able to do this. But if you don't have that, it would definitely help to have better tools. Rick, over to you.
Rick, please.
I think you said it all. You said it all, Kamini, and I think this came up in a couple of the Q&As. Someone else brought that up. I mean, if you've only got 100 cases or 28 cases in Bhutan, it can be a lot more intense, and that's the advantage that Dr. Rosanani showed us in Malaysia, in Bhutan, in Sri Lanka. At the end stages, it's a very different challenge. But when you get 2,000 cases coming into Papua each week, and other cases in Pakistan, the deluge is a completely different challenge, as Dr. Abdul mentioned. So I think we do need some new strategies to bring the burden down to somewhere where we can do that. And it may be that those strategies change as your burden of malaria comes down in a country and you head towards elimination. But we have some fantastic new tools. We can promote much better G6PD testing than we have been doing before. And we can really appreciate that just giving people tablets and expecting them to take 14 days when they're better after 3 days, it's probably not a great idea. So we've got ways to deal with it. And I think, that's very exciting. We should use it as an opportunity.
Great, thank you. And the second most popular question, again for our presenters, I think, not an easy question, but which Vivax treatment regimen, PQ7, PQ14 low dose, high dose, or Primaquine, would you recommend for a high burden country with a malaria elimination goal of 2030?
Rick.
Well, that's $1 million question. I mean, I think the most of the world are using the low dose Primaquine, and in some places that works very well, even in a high burden country such as India and in Nepal. The Rijal paper, the JID last year or the year before, 95% efficacy with a low dose Primaquine regimen over 14 days. Works very well. But in other areas, not so good. And my worry is that while everyone is using the 14-day low dose, there are places where we really do need a higher dose, particularly places like Papua, PNG, Brazil even. I mean, if you use the low dose there, you're only getting about 65% efficacy. So I think this is $1 million question. Most countries just want to go for the low dose because they're scared of using the high dose. But we've shown that if you use the high dose, even at seven-day regimen, Cindy Chu's paper on the Thai-Myanmar border and Improv showed us that actually you can get to 90% efficacy everywhere. So do you need the high dose everywhere? We don't know. And there are going to be some very important studies coming in. The Cochrane review is coming out, looking at that at a level overall. And then we're also going to be doing an individual meta-analysis to try and work out what is the optimal dose for safety and efficacy and give that at a country level. So it's going to vary. And it's not just about high burden countries and low burden countries. It's going to depend upon the relapse periodicity. And there's a lot of unknowns in there.
Thank you very much, Rick. The next question is perhaps more for our panelists, and the question is about ongoing or planned research on safety for the 8-week Primaquine regimen in countries with severe G6PD variants. So perhaps Dr. Abdul, can you comment on that, if there is anything planned in Pakistan?
In Pakistan, as per my knowledge, at the national level, we are not doing. So as I mentioned earlier, we have scarcity of all this research initiative studies going on. So as far as my knowledge is concerned, we don't have any study ongoing.
Okay. Solly, Dr. Solly, any work ongoing on 8-week Primaquine?
I think we have primarily discussed with some partner, because we understand that 8-week Primaquine is not safe for the G6PD deficiency, as we have some study in Cambodia in 2013. So we are now try to use another regiment, but not yet officially, but start to discuss so whether we can use chloroquine intermittent to provide to G6PD deficiency for the patient or not in the future. So this issue just in the research issue that we discuss with partner, and then if we will discuss with WHO if they are concerned and they found that it is useful for the program, and then we might start to do the clinical trial. So this is our plan. Yeah.
Thanks for sharing that. Dr. Rose, do you want to comment on that question as well?
Yeah, currently we have more on research on the validation of dossier, because we are on the way to get in the process of getting validation from WHO, and we are doing that. And at the moment, we in terms of Primaquine, we do not have any study because it's already our policy in the treatment of malaria, so it's already established. However, maybe way forward, if Primaquine registered in Malaysia, we might have a study on Primaquine treatment in malaria patients.
Thank you. So coming back to the 8-week Primaquine, is there Kamini or Rick, did you want to have any comments on that question as well?
Can I say something?
Yes, please go ahead.
Yeah. So all I can say is that I do know that some countries are using this. This becomes, I think, important sometimes in the after elimination, in the prevention or reintroduction phase, such as in Timor-Leste. You see, during that phase, some of the patients you're going to get are not your nationals. They're going to be foreign nationals. You have no idea what the background status of G6PD is in their country of origin. And so this is the case in Timor-Leste just now. Many of their cases are from Indonesia, and they've started using the 8-week regimen, and I think they're quite happy with that. Adherence is a problem, but they have so few cases that they can follow them up by telephone, by visits, and so on. So that's not an issue. But before can I just Kamala, can I just touch on an aspect which we've not spoken of here at all during this the tech talk, which
yes,
is
of course,
the private sector. None of us mentioned it, but the reality is that a lot of patients, especially in the high burden countries, they seek health care for malaria in the private sector. Now that adds another level of complication to this whole thing. And that's why I think, again, tools come in here again. So it's something, I mean, I know, for example, Dr. Abdul, in Pakistan, quite a large proportion of patients seek healthcare for malaria in the private sector. And it's a case in many other countries as well. So let me stop there. And Rick, you want to say? Take you on.
On 8-weekly Primaquine, very little data actually. Bob Taylor did a review, I think, with Lek in Cambodia, and we had 50 patients in the IMPROV study from Ethiopia, Afghanistan, Vietnam, and Indonesia, and I can tell you that hasn't been presented yet, but actually it worked very well if you can supervise 8 weeks. If anyone wants to see that data, please could you email Bob Taylor, and I'll give you his email address and ask him to finish writing up the paper, because that would be great. So there is data coming, very little data on that. But is it a reality? Is that really feasible to give people 8 weeks, and can you follow people through? I think it's going to be very difficult, and ideally, you know, you're going to have to G6PD test, then what are we going to do? Could be prophylaxis is another option that some people have used, but again, that's also difficult. So it's very difficult. But 8 week does seem to work and is reasonably safe, although not without issues as well.
Thank you very much to everyone. The next question is around which countries are conducting feasibility studies for safe and effective radical cure. And I think it probably, Caroline, you might be best to answer this one.
Sure. So good question. So there are a few feasibility studies in the pipeline. One that should be starting soon is in Thailand, and that's on the use of quanti-G6PD and Primaquine. That hopefully, touch wood, will start this year. The aim of that and all the other feasibility studies is to try and generate evidence as to how we implement these new tools within the health system. So as opposed to the clinical trials from before to prove the efficacy of the studies, it's how we really try and address those various challenges that the panelists highlighted in terms of access to community level or use at lower levels of the health system. So the other studies that are taking place kind of outside this region also planned are Ethiopia and Brazil, which is a large one. And then moving back to this region, we've got one plan for Myanmar that will be a little bit later, probably in 2021. And also 2 more, which Kamala and Rick can probably speak to more on the feasibility of using PQ7 in Indonesia and PNG. So the Brazil, Thailand, Ethiopia, Myanmar feasibility studies will focus on Primaquine, and Indonesia and PNG on PQ7.
Thank you very much, Caroline. We'll move to the next question, again for Professor Kamini. It's around statement is that in the GMS countries, most of their countries are already applying some sort of supervision or follow-up or DOTS in certain circumstances at least. Yet it is challenging to encourage adherence. And while policy change for new tools will take a while, again, looking at the practical strategies at the moment and the limited resources, how does this fit in with the current COVID situation? And what would be your recommendations for countries in, I guess, to focus their scarce resources? You're muted. Can you unmute, please? Thank you.
Yeah, thanks. Yeah, that's a difficult one. I completely agree with what they say about the difficulties in implementing the the 14-day regimen to get adherence. But in most of the GMS countries, the burden of Vivax is fortunately coming down. So I think, you know, when the volume of work decreases, it's possible to focus a little bit more on individual patients, and that's where I think the win-win situation. When you bring the burden down, then it becomes easier to do the next bit of control towards elimination. With the COVID situation, this is challenging. I mean, all this requires interaction with patients, with community health workers, going to patients' houses if necessary. But I mean, I have no solution, shortcuts to this, but I think it has to be done. I mean, countries are doing it. I mean, some of the, I mean, one interesting connection between the COVID situation and malaria is that because most countries are in lockdown and countries are getting malaria patients from overseas, these are the countries I'm referring to are the ones that are very near elimination. So they have very few of indigenous cases, but most cases are imported. Then all the foreign nationals are in quarantine. So they have a captive population who have malaria, which is easier to deal with, but that's an exception. This applies only to countries that are in the elimination phase. In the others, I have no solution, but what I want to say is that it's impressive. Countries like Myanmar, Thailand, they are doing a fantastic job with giving radical cure and getting adherence. And as I said, I mean, adherence is a matter of really taking the time to explain to the patient. You know, some of the best studies on this were done in Pakistan, in fact, Dr. Abdul, by Mark Rowland, in which he showed that if you really talk to the patient for a short while and tell them the importance of this, and also to the caregivers, you can get very high compliance, adherence. So I'll stop there.
Can I just add to that, Camille? That's very nicely put. I mean, Francois just put a question up here. Is if you treat, if you diagnose and treat very aggressively, malaria will come down, and eventually Vivax will eliminate, even without radical cure. And so that is an option, but it doesn't get away from the fact that we've got to be intensely diagnosing and treating to make that impact. I think even in high burden areas, we've got to remember that 80% or up to 80% of recurrences are actually due to relapse. So even if you go into high burden countries and do things well, we should see a dramatic drop. And the modeling shows that, and actually some of the experience that we've seen in some countries, when you do radical cure properly, it can come down quickly. So again, it comes back to the time matter. Can we do this within our elimination targets, in which case we are going to need radical cure.
Yeah, can I come in here, Kamala, for a minute?
Okay, 1 minute. The clock is ticking.
Okay, so it's interesting that Francois says that it's possible to eliminate malaria without radical cure. I mean, he probably is right, but I think it'll take a little longer. To do that. And yeah, okay, I'll just stop.
The clock is ticking, as I mentioned, so we're coming to an end. Before we close, I just want to have a quick round, particular to the three panelists, to give us a brief idea of how we can, I guess, design the next couple of tech talks and what tech talks and what they think would be the most important questions to address in more detail. And in the meantime, can I ask Chris to put up the poll for the participants to answer a very similar question? Dr. Rose, can I start with you? Just very briefly, even keywords, what do you think are the most important things that we should discuss in the next Vivax Working Group Tech Talks? You're still muted. Can you unmute, please?
In terms of, I think we need to look at the cost-effective strategy of radical cure for Malaysia, because we already in Malaysia we already all the newborns are tested for G6PD. So G6PD testing is not an issue in Malaysia, but of course the treatment and to find a treatment that to replace Primaquine with 14 days to a shorter days, because that is the challenge for us, to keep patient in the hospital for 14 days to complete their treatment. So if we have a shorter period of treatment, it's much better for us.
Thank you. Dr. Abdul, very brief, what are the most important topics for the next talks?
I mean, I think in a country like Pakistan, where implementation of regulation remains a big challenge. So, like Professor Mendes mentioned, so adherence, in my opinion, we are catching only few patients, diagnosing. So, at least, I mean, as a first part, we need to ensure that they remain adhere with 14 days anti-relapse therapy. So that from my side.
Thank you very much. Solly, very brief, what are the next important topics to discuss?
So I think we stick to implementation of GCPD testing, challenge and opportunity. But since the implementation so far, so I think their strategy to measure and improve adherence also important to understand whether patient had complete the radical cure treatment, so that consider as important in order to when we want to use the short course or longer course, so that is most important.
Thank you very much. So we come to the end of the webinar. We're already a little bit over time. I know there are heaps of other questions in the Q&A, and we'll try our best in the next couple of days to answer those in written, and obviously those written answers will be then available with the recording to look at. It's great that there was so much interest. Appreciate this a lot. I think there is going to be a second poll. Chris, if you can put this up, it would be great if people could answer that as well before leaving. So I'd really like to thank our fantastic panelists and our fantastic speakers and my co-moderator, Caroline. You want to switch on your camera again? That would be amazing. Thank you very much for everybody. Thanks for attending. And I hope we see you next time. And thanks obviously for those behind the scenes, Chris and Phone, who did all the technical things and helped us to get this all sorted out. Thank you very much. Bye.